right. So thank you everyone once again for joining our session, Digital Training and Innovation Expanding Capacity for Community Health Services. This session is a core element of the 4th International CHW Symposium, showcasing new evidence, innovation, and direct field experiences from around the world. On behalf of the organizing team, I'd like to once again extend our sincerest congratulations to all of our presenters who were selected from a highly competitive pool of abstracts.
Thank you so much. So hi everyone, and welcome to the session. So thank you, Anam. My name is Monica Descott, and I am a learning experience designer from Digital Medic, which is an initiative of the Stanford Center for Health Education. At Digital Medic, we really focused on making sure that all communities have access to engaging, evidence-based, and actionable health information. Today, we're going to be talking about how we co-created a digital training course on common childhood illnesses with our community health workers, but for community health workers as well. So we actually joined by one of our collaborators on this project. Muma, can I please ask you to introduce yourself?
Good evening, everyone. My name is Muma Idelquin. I'm a program manager for Lwala Community Alliance, an organization that unlocks the potential of community health workers and advances the comprehensive well-being of communities. At Lwala, we train community health workers to be able to bring services closer to the communities that they are working with. We also strengthen accountability mechanism systems within the community. We improve quality of healthcare within healthcare facilities, and we also ensure that we work very closely to deliver data-driven solutions underpinned with policy, advocacy, and ensure that every model that gets through our hands and that communities lead the process, and so that there is sustainability. Thank you. Over.
Thank you so much, Muma. We also joined by my colleague, Jamie Johnston. She's our Research and Evaluation Director, and she's available to answer any related questions during our discussion. So at the very start of our project, our aim was really to develop a course that was focused on a high-need health area. So to fill a really specific identified need and gap in health education. So Muma, as a collaborator on this project, what need did Lwala and your community health workers have?
Yeah, for Lwala, it was very important in equipping community health workers with the right skills and with the right knowledge. Therefore, we came into partnership with other experts and the community health workers to deliver a training module, which is digital, that would ensure that it's practical, it relates to the real-life experiences of the community health worker, and ensure that the module that was delivered would be scalable, reaching wider audiences, and the CHW, that is the community health worker, would easily relate to it because of the flexibility of being able to learn even of course when they are not physically present, and even do other assessments. So based on that need, Lwala saw that this was important to also reduce the costs in managing the scale, and also because for childhood illnesses, this is so important for Lwala, and especially while working with community health workers, because we partner very closely with the Ministry of Health to ensure that we reduce child mortalities and morbidities, and knowing that community health workers are trained to deliver, manage first aid at home, and only refer complicated cases. So this was very important because we know that community health workers can prevent avoidable deaths and also ensure that they manage other cases at home, relieving the health systems of the burden. So this was very important for Lwala, especially in its scale-up program. Yeah, thank you.
Thanks, Mama. And, you know, this wasn't just a locally identified need. It is also a global priority in terms of, according to UNICEF in 2019, nearly a third of all deaths in children under 5 were caused by illnesses that are largely preventable and treatable. So as Muma mentioned, trained and skilled community health workers play a key role in identifying these signs and symptoms of childhood illnesses early and then helping caregivers get the right treatment for children. So by empowering community health workers, we can actually change these statistics. So the real need for the project was to provide community health workers with practical evidence-based training on childhood illnesses and really ultimately improve child health outcomes. So who made this happen? We were funded by Alma Philanthropies, and we co-created this with a core group of community health workers, a sample of our target learners from our collaborating organizations. And our collaborators on this project was One-to-One Africa, Palani, which is both of them based in South Africa, as well as Lwala Community Alliance based in Kenya. So to create the training course, we follow the ADDIE model, which really consists of 5 key phases. So the analysis phase looks at understanding and exploring the learner's needs. Then we design and define the content. We develop and create the learning materials. We share the content with our learners. And then lastly, we evaluate the impact and effectiveness of the solution. But really underpinning all of this is our human-centered design process. So what this means is that we co-create the training with inputs from our target audience, who were CHWs in this instance, as well as our collaborators on the ground. And we obtain their input and their insights throughout each phase of this development process. So as you can see, these iterative loops, these dotted lines, get smaller and smaller as we move through the phases and further iterate and refine our solution. So what I'd like to do is actually just zoom in on one of these iterations just to give you an idea of what this co-design process could look like in practice. So really at the beginning of our project, we conducted many stakeholder discussions with our collaborators, as well as focus group discussions with our learners, and got their input, got their feedback multiple times through these iterative discussions. And as we went through these, we further refined and defined what the course design would be until we came up with a final course design. So Muma, as a collaborator through this whole co-design process, what was your experience creating the course with Digital Medic, with other experts, and with community health workers themselves?
Yeah, this was very insightful. It was a very deep process, very comprehensive, taking into account the various policies, the guidelines from the various countries that had to be put in place, the context of the CHP, that is the community health promoter worker, their real life experiences, merging on-ground real life experience and expertise. And it enabled us develop a digital training module that was very efficient for the community health promoter and was very practical, relatable, and eventually was integrated during the integrated community case management training for the community health workers by using the videos and the job aids that were developed during that session. And it brought the trainings for the community health workers alive. And the fact that they could refer back to some of those training aspects even after leaving the training was very key. Another thing was that from the training, the co-design process, we ended up developing or tailor-making content that was very specific for the end user, and that is the community health worker, which was a plus. Thank you.
Thank you so much for that feedback. I just want to give you a brief snippet of the final solution that we eventually came up with.
As a community health worker, you may see children with a cough, fever, diarrhea, or other symptoms. Join me and my colleague John as we teach you how to identify the early signs and symptoms of common childhood illnesses for children between 2 months and 5 years of age. Learn how to decide if a child can be cared for at home or if the child needs to be referred to a health facility for urgent care.
So the course was really designed around key signs and symptoms that community health workers would encounter in their communities when they're doing home visits. And the content can be accessed on any device, both online or offline, and has a number of different learning elements. So I want to show you a quick example of one of the videos that we created. It's just a short snippet, but it shows the skill of identifying fast breathing in a child.
Look at how the chest expands, or gets larger and moves up when the child breathes air in. Then the chest contracts, or gets smaller and moves down when the child breathes air out. You will be counting the number of times the chest expands when the child breathes air in 1 minute or 60 seconds. When your timing device is ready, start counting the number of times the child breathes in and their chest expands for 60 seconds. If the child moves or starts to cry, stop counting. Wait until the child is calm and start counting for 60 seconds again.
So that was the video. And then we have the accompanying job aid, which is a summary of the steps that the community health worker would need to follow. And it acts as a refresher and job aid in the field. We also conducted piloting and testing, one-on-one in-depth interviews with our community health workers to understand how they interacted with the course and the course materials. Just in summary, I've briefly walked you through our human-centered design process today, from identifying a really critical knowledge gap for our community health workers to building an educational course with them. So far, our results have shown that involving community health workers in the process really creates something relevant, useful, and contextual. And we're constantly looking for further funding to further evaluate outcomes on this course. But a great resource is only great if it's being used. So the challenge really is for all of you to get this content into the hands of our community health workers. Please share the course widely. It's freely available to share, use, and download from any of our channels listed above. Thank you so much.
Thank you. Thank you so much, Monica, Mama, and Jamie for that insightful presentation. It's inspiring to see how co-designing with CHWs can create contextually relevant and user-friendly digital tools. We'll go ahead and quickly stop for a quick Q&A. I know our presenters have been actively responding to questions, and I'm just going to check for any others if we have. There are a few open questions, so if you can please go ahead and answer those. And we actually have a few questions that we would like to pose to our presenters. First and foremost, Monica and Mama, were there any limited, like in a limited resource setting, e-learning and digital learning can be challenging? How did CHWs react to using a mobile app for learning compared to like an in-person training?
Thank you for that. I'll start with answering. So limited digital literacy is always a challenge in digital solutions. We do try, and so in our one-on-one in-depth interviews, we did try and pilot the solution to get information on the usability of our digital platforms to see, how user-friendly it was. And community health workers were fairly positive about being able to navigate the digital technology. We do also experience, though, the challenges of lack of interconnectivity, smartphones and data and all of that. So on our app, we provide the opportunity to view content offline, and we also make sure that we focus on creating learning that is really small and doesn't take a lot of space on users' devices. So yeah, that's a bit of feedback from my side. I don't know, Muma, Jamie, if you want to just jump in and add anything.
I think you've said it all. It was a breath of fresh air, and CHW these days are used to use phones because everything is going digital. And having them within the context of designing was very important, and they found it very interesting, and it was a breath of fresh air. Just breaking off from the normal curriculums and having the videos and the job aids, which were very relatable. Apart from the internet, the data bundle challenges that we have to deal with from time to time, as Monica has mentioned, this was sorted by being able to support them to download the content earlier, and they even have them in their phones, and they can be able to refer to them because it's much easier for them to relate to that, other than the very bulky curriculums that they have to carry along in terms of manuals. Thank you.
Perfect. Thank you both. I believe we've answered all of the questions that had come in, so I'd also like to give our speakers a chance to ask questions to each other and your team members on things that you would like to further elaborate on. So the floor is open for our speakers.
Can I start with a question? And it's to my fellow speaker, Muma. So during our content development process, we did an extensive analysis of reviewing all the content that was out there. So that was our collaborators, CHW curriculums, the Kenyan Ministry of Health, ICCM curriculum, as well as international guidelines from, like, for example, the WHO and UNICEF. Muma, we spoke about co-creation with our collaborators who work on the ground, as well as with our target audience and community health workers themselves. But I wanted you to maybe just share a bit more about another collaborator whom we haven't spoken about, and that is the Ministry of Health. If you could maybe share a bit more about how you worked with them through the course development process and how important it is to get their input and buy-in throughout the process.
Yeah, thank you, Monica, for that question. Indeed, we work to support and facilitate the work of the Ministry of Health, and all this would not be possible if they were not part of this whole process. So from the process of reviewing all the modules, they were there to give the technical guidance in terms of the policy directions, the scope of the CHW roles, what they're allowed to do based on the guidelines in the Ministry of Health. And so they also gave a lot of insight into the work that was done in developing the modules. And not only that, but also during the training when we were trying to see how to integrate this digital training process into the normal training with the CHW curriculum, they were very integral in helping and ensuring that actually fitted into the normal curriculum that we've had. And that was very important, because otherwise, where would we have rolled out this particular digital content if it were not for their ownership and that they took up this? Because for you to do anything to scale, then the Ministry of Health has to take it up and has to own it. And actually, they went on with it and rolled and thought that this was a very good module. So right from the inception on how the modules were being developed, the technical guidance, the policy direction, how this would fit into the already existing training modules, what is possible, what wouldn't be possible, was made possible by the Ministry of Health. Thank you, Monica.
Thank you so much. Muma, just to add a follow-up question to that, you mentioned the implementation and the integration of the digital content into your current training. Could you share a bit more about how you are conducting that training and what that integration process looks like?
Yeah, thanks, Monica. So the first thing after the content was developed was going ahead to, of course, engage the Ministry of Health to train trainers into understanding how do they integrate the digital content into the manual, the physical manual that was already developed. And during the training process, then bits and pieces of the job aids, the videos were used just to try and see. And this was very interesting because they brought out how we could even further make this possible for the CHWs in terms of downloading them, in terms of even modules that were heavier to download or access than others. And I think that like the vaccine module, which was a bit heavier than all the rest. And they were also very glad that some of these videos or training aids made their training much more easy. So it was a very interesting process to see them getting engaged during the training. And yeah, they really did a good job in this. And even for the subsequent trainings, this is now the integrated module is what is being used for training the ICCM, because they found it to be more relatable for the CHPs, more practical, and more palpable, that CHPs were finding it easy to relate. And they also had now a more harmonized standard materials in terms of, let's say, when you have cough or when they want to explain fast breathing, things like that, it was more easy for them, standard across all the training sites to know what to do. Yeah.
Thank you so much.
We have a question for Digital Medic on how you are able to work with the government in development of the modules and perhaps the process of interoperability into MOH tools.
So this is a difficult question because it depends. So it depends on which Department of Health or Ministry of Health we are working with. And our real goal is always to ensure that the Ministry or Department of Health is included in our projects from the very beginning. So including them from when we start that analysis phase and we start investigating the need, so that they are part of this co-design process with us and they are part of providing that input. And that then ensures that there's that alignment, there's that buy-in, and they are part of the process and have included their key insights and feedback into the content that we develop. In terms of interoperability, that is a challenge still that we're dealing with, because there are various tools that are being used by various departments of health. We are working on a project in Uganda at the moment, and really our key objective would be to get this learning integrated into the systems and into the tools that the Ministry of Health are using, so that as they are busy collecting data, they have the learning resources with them, as complementary aids. So it is a challenge that we are still struggling to come to grips with and figure out, how to make all these systems work together and complement one another.
Perfect. Thank you, Monica. I think there was another question that came in. If you can just answer that by typing it, as we're going to start closing this session. As I wrap up, I'd like to express my heartfelt thank you to all of our presenters, Monica, Mama, Edna, Mehdi, Dr. Emmanuel, and Arthur, for sharing such rich insights across continents and disciplines. Across every presentation, one message stands out very clearly. Digital innovation is not replacing community health workers. It's empowering them with the tools and the data and the confidence to deliver better care. On behalf of the organizing committee, thank you to our audience for your engagement and thoughtful questions throughout the session. Please stay with us for the next symposium session. We have one that's ongoing right now on strengthening CHW roles to deliver Hep B birth dose. And we have a session starting in 2 hours on CHWs in crisis contexts. Please feel free to continue conversation in our networking lounge. We hope that you enjoy the rest of the symposium, and thank you once again for being part of this very important discussion. Thank you, everyone.
Thank you for facilitating. Thanks to everyone. It's a real pleasure.
Thank you so much, everyone.
Thank you.
Thank you, Anna.